Now, Health Minister Dr. Joe Phaahla has told journalists this week that his department is expected to cut around 1 billion rand on TB, HIV and the AIDS budget. Now, this money, we're told, is meant to be redirected to fund the country's social grants program. The minister was speaking during the State of Health media briefing this past week. For more on what we should make of some of the remarks that have been made, let's bring in Professor Musa Moshabela, who's the Vice-Chancellor for Research and Innovation at the University of KwaZulu-Natal. Also joining us is the Minister himself. Both our guests joining us via our video link this morning. And it's great to have you on the program. Thanks very much indeed for making time. I wonder, Minister, if I can begin with you this afternoon just to ask a clarity-seeking question. When you spoke about that 1 billion rand that's being moved from the fight against TB, HIV and AIDS, where was it, or where were you saying it was headed? Perhaps you can just clarify in your own words what you were actually responding to at that time.
Well, the question was about the impact of the cost-cutting measures on the health sector. So what I've indicated is that as a health sector, we will contribute towards the tight fiscus, the tight financial situation, which we are aware of, which the Treasury is trying to get the whole of government to address the fiscal situation, which the Minister of Finance will speak more of. But as it's public knowledge that there was a letter which was circulated by Treasury alerting heads of departments, DGs, that there is particular, stress on the fiscus. So our team has been discussing with the Treasury, looking at areas where we can make a contribution, but we are also conscious of the fact that where we can identify areas where we can make such contribution, it should be where we think there will be savings, looking at the expenditure trends. So the area of the conditional grant on HIV, AIDS and TB is one of those areas. And there are a number of factors. Our rollout of ARVs is still well on course. Actually, more and more HIV positive people are coming forward to get treatment. As I indicated on Thursday, we are spending now just over 5.8 million people on the ARVs, and also the TB treatment we are increasing. But the cost of some of the treatment, especially the big one, which is the ARVs, we've been able to negotiate further reductions. Also with the new treatment regimens, we have been able to experience savings. So with the trends as a result of some of those savings, from the current allocation, we believe that we will not be risking a lot in making some contribution,
right,
to the fiscus. Yes.
Because that was going to be my next question. How is this likely to affect your own targets? Because you've admitted before to Parliament that we're unlikely. In fact, I think we have missed the 1990s target. It was meant to be reached in 2023. It was partially because of the COVID-19 pandemic, and we'll ask the Prof to weigh in about that in just a moment. But how is this reallocation potentially affecting that?
Well, the situation is that our current calculation, just to give you an example, that a year ago, per patient per annum, we were spending 120 rand. With the current prices, because also having the biggest ARV program in the world, we are able to negotiate prices. Currently, that has been reduced, and with also from, remember that we've come from where the number of tablets per day, a number of pills per day, currently is 1 pill, and that also contributes to the reduction in cost. So from 120 per patient per annum, we are now sitting at 80 rand. So a significant saving. So we are still increasing the uptake, looking for people who are not on treatment to get them on treatment. So we are not, the issue of us not reaching our target of 90% of people who are HIV positive being on treatment, we're still just below 80. It's not because of lack of the treatment availability. It's more of people being convinced to come forward to start on treatment. We do have the capacity.
Sure.
So yeah, that is the difference. That it's not a lack of the treatment that that's why we are going out for advocacy into the local areas to find an additional estimated 1 million people who are positive, who have been tested but are not on treatment.
Sure. And part of the reason, Prof, we're told why a lot of people aren't potentially coming forward is because of the disruptions brought forward by the COVID-19 pandemic. In the economic side of things, we've had business leaders telling us that they are yet to get back to what things used to be before COVID-19. And I wonder to what extent, Professor Moshabela, we can say the same about health in this country.
Yeah, Ayanda, greetings, Honorable Minister. So I think for me, the issue of the cuts in terms of funding comes at a really bad time. Of course, it is also a consequence of the economic downturn, which is happening at a macroeconomic level, but also at a household and at an individual level. A lot of people are feeling a pinch. And remember that when people are supposed to go to the clinic, they also need to have money to go to the clinic. And if they don't have that money, they're not going to go to the clinic. And that can lead to people either not initiating treatment or not coming back for follow-up to collect their medicines. And if they don't, we end up with a situation where we get more people with HIV, we get people with complications from HIV, which is going to cost us even more. So basically, it's a vicious circle that if we are not going to find a way of addressing it, eventually in the medium term and in the long run, it's not necessarily going to ease our fiscus, ease pressure on the fiscus. So I think that, Ayanda, we really need to be thinking out of the box in terms of creative ways of doing things differently. At the moment, I think that what we saw from COVID is that you can't just focus on the supply side of making an intervention available, for example, a vaccine or treatment. You also need to make sure that somehow there is willingness, there is activation of the population to seek out that treatment and engage with it. Otherwise, we don't see the benefit at the population level. We have come a long way with HIV. We've come a long way with TB. In fact, we were on course to probably reach the 50% of TB 2025 and TB target. But these things that are happening now are making it difficult. And it is compounding. For example, in KwaZulu-Natal, it is compounding on other environmental issues where people have not recovered from issues around floods, people have not recovered from storms, people have not recovered from issues around load shedding and so forth. These things are creating sort of a pot that makes it difficult for people to cope with the demand for care. So I do think that we need to think about a different way, perhaps more multi-sectoral approaches. Instead of just looking at the budget for health, combine the budget for health with social development with another one at a community level, and think about how to bring it all together to sort of target several problems at the same time, instead of waiting in the clinic for people to come, because these problems are making it difficult for them to come into the clinic.
Absolutely. Also joining us is Health Minister Dr. Joe Phaahla. And Minister, let's kick things off in the second half with you once again. The Prof spoke about innovative thinking in order to finally get this right and achieve those targets that have been set. In your 2022-23 budget vote in Parliament, you highlighted that a major concern for your department is that amongst young people, especially girls, you're seeing a rise in HIV infections. I wonder what you reckon it will take to reach specifically that population and finally turn the tide on that trend.
No, definitely that's what we are concerned about. There is a steady reduction in new infections, but it's slow. So in terms of our size of burden of HIV, we're sitting with an estimated 7 million people positive for HIV. And even though we're already at just under 6 million people on treatment, we're still short of 1 billion. But the fact that when people are on treatment, which is why also we're driving that, it helps to suppress. Once the virus is suppressed, it's also not transmissible. But even if, as we make progress in that, the key issue is to stop the tide of new infections. So we're not quite happy with, even though there's a decline. So we are looking at various ways, and as Prof was saying, part of that is we need to find more ways of getting to where the young people are. The higher education, the schools, just on sexuality awareness, but also innovative ways, including social media. So we're looking at various ways in which we can, our messages, even, we're also self-critical to say some of our messages maybe are no more resonating well, especially with young people. So we want to bring in, we've got also your influencers, and we're looking at all those who can help us to reshape our messages. But we're also saying men, for instance, generally don't come forward for seeking help. So, and in our last meeting with the MECs, we're looking at how to go out, and as Prof was saying, rather than waiting for people. There's been reports which showed that when we go out more often to taxi ranks, and including even for men, even to taverns, there has been reports of some such programs which have yielded more positive results. So those are the things we are looking at to read, because rather than, as Prof was saying, we learn from COVID, rather than just waiting, and we must find ways also to make it easier for people to know what is available and how to get tested and how you can then be put on treatment. So sure, we're looking at all those innovative means to reach out to people.
Right. And Prof, what does the research tell us is the best strategy to potentially do this?
Yeah. So if you look at methods that are coming in the field of, a science called implementation science and impact science, basically what it's saying, Ayanda, is that you cannot have one approach for everybody. Traditionally when we design programs, we design one program for everybody. But now what we need to do is to basically segment the population that we are targeting into different groups based on the similarities in what drives the problem or the infection. So you might find that for young people, you need a different approach. For men, you need a different approach. For men who have sex with men, a different approach. For pregnant women, a different approach. So you need to segment the population and develop the strategies according to the drivers in that particular population. And most importantly, there are designs that are called human-centered design. So which means that you co-create the interventions with the people that are affected. You don't just sit, in your office and design a program for them. You actually go onto the ground. You co-create that intervention with them in a way that can work best for them and adapt it accordingly as things change on the ground. So these are called human-centered designs. These are, innovative ways that one can start to use when you are finding yourself in a tight spot like we are now, so that you can get the most out of the investments that you're putting in.
Yeah. We spoke earlier about reaching different people in the lives that they live, Minister, and I suppose there's been also a lot of conversations about ways in which, for example, the people or the population of sex workers could also be kept safe, when it comes to our ability to prevent a further spread of HIV and AIDS. Initially this year, there were discussions about changing legislation in order to make sure that even just the language around this, how the law sees people in this profession, can assist. How far is that, at least as far as you know, and how far do you reckon it could go in order to achieve these goals?
We've gone a long way in terms of, and working together with the sex worker community. We do, within the South African National AIDS Council, amongst various components of the civil society in SANAC. We do have organizations which represent sex workers, and we engage, very formally with that community. We get their own input. They remain quite unhappy with the fact that we have not decriminalized sex work. But our colleagues in the Justice Department have been working on changing the legislation in that regard. But it's a very sensitive area because equally so, you do have sections of society which are totally opposed to total decriminalization. So what we can say currently is happening, it's sort of, even though the criminality remains in the statute book, but I'm sure all of us know that, you hardly hear in any magistrate court these days where police and prosecutors are bringing somebody to court on the basis of sex work. So there is sort of a soft hand, although what the community of sex workers, for instance, still complain is that while on the health side, we provide them with pre-exposure prophylaxis, which is the pills which they can take, because they are a high-risk population. So those pills prevent, if you are using them, if you get into sex with somebody who's positive, it doesn't transmit over and above the condoms. But then they will complain that we give them free condoms, but when the police, are doing their raid, they then confiscate the very condoms. So that's a matter which, and the police will say they're just carrying out the fact that the law is still in the statute books. So, we try to urge the justice side, especially the police side, to just go steady on that. Of course, until the law is changed, they say their hands are tied. But it's a soft approach at this stage. So, yeah, so basically that's what we are doing, example of the sex work community.
It's a fair point that they make. It almost seems that the right hand is not aware of what the left hand is doing, and that speaks against the point that Professor Moshabela was raising about there being greater cohesion even across departments in order to get these things right. But that's the time we have this afternoon, and really do appreciate both your insights, Health Minister Dr. Joe Phaahla and Professor Moshabela, who, of course, is the Deputy Vice-Chancellor with the University of KwaZulu-Natal. To both of you, thanks very much.